Welcome to the deep dive. You send us the material, we pull out the essentials, basically your shortcut to getting what matters on complex topics.
And today we're diving into something really important, especially if you're revising. Acute angle closure glaucoma, AACG. We got a great overview from a listener.
Yeah, fantastic notes. So our mission today is to turn that into, a really clear, high-yield guide at ophthalmic emergency, so definitely need to know stuff.
Exactly. We'll cover the definition, the causes, who's at risk, what it actually does to the eye.
What else it might look like, the classic presentation, diagnosis, treatment, the whole picture, really.
Right. Prognosis, potential problems if it's missed. Think of this as your focused revision session. We'll try and use some memory aids to make it stick.
Perfect. So where do we start? Definition seems logical. What is acute angle closure glaucoma?
Okay, so AACG. It's a sudden, really severe eye condition. It's classed as an ophthalmic emergency needs sorting out fast.
And it falls under the umbrella of glaucoma, right?
It does. Glaucoma is basically a group of disorders that damage the optic nerve. Often, but not always. This is linked to high pressure inside the eye, the intraocular pressure, or IOP.
Ah, that's a key point from the notes, isn't it? High IOP doesn't automatically mean glaucoma.
Exactly. And you can have glaucoma with normal pressure. It's the nerve damage that defines it.
Gotcha. So what makes AACG special, or specifically acute?
The core issue in ACG is blockage. The fluid at the front of the eye, the aqueous humor, normally drains out through a sort of meshwork in the angle between the iris and the cornea. In ACG, that angle gets blocked.
Like a plumbing backup.
Pretty much. The fluid can't get out, so the pressure inside the eye shoots up really quickly, dramatically.
And that causes symptoms. The notes mention some classic ones.
Absolutely. Hallmark symptoms are a very painful red eye. Vision gets blurry, fast. People often see halos like rainbow rings around lights.
That's interesting.
Yeah, and because the pressure spike is so severe, it can even cause nausea, vomiting, maybe a bad headache. And the people in that eye might look a bit bigger, sort of mid-dilated, and not react properly to light.
Okay. The notes also differentiate between primary and secondary ACG. What's that about?
Good point. Primary ACG, you might see it called PACI, AAC. Sometimes they're used interchangeably. The underlying issue is usually something called pupillary block.
Pupillary block.
Yeah, where the iris kind of bows forward and makes contact with the lens, stopping the aqueous fluid flowing easily through the pupil to the front chamber. That pushes the peripheral iris forward, closing the drainage angle.
Right, and secondary.
Secondary ACG is when something else is pushing the iris forward and closing the angle, like inflammation, a tumor, maybe abnormal blood vessels. An external factor, basically.
Okay, that makes sense. The notes also mention stages of primary angle closure, just for context.
Yeah, briefly. There's a latent stage, just the narrow angle, no symptoms. Then subacute, maybe brief episodes of blur or halos. Then the acute stage, that's our focus today, the emergency presentation, often seen first in primary care.
Yay.
And then there are chronic and absolute stages, more long-term damage. But the acute attack is the one we really need to recognize quickly.
Definitely. Okay, so that's the what. Let's move on to the why, the etiology. What's the root cause?
The main cause is that anatomical narrowing or closure of the drainage angle we talked about. The space is just too tight.
And that physical blockage stops the aqueous humor outflow.
Leading directly to that rapid, dangerous rise in IOP. Yep.
Are there specific things that can trigger an acute attack in someone who already has narrow angles?
Yes, several triggers. A big one is pupil dilation.
Why is that?
Well, when the pupil dilates, the iris bunches up in the periphery, making that already narrow angle even shallower, potentially blocking it completely. This can happen naturally in dim light.
Ah, like going into a dark cinema.
Exactly. Or it can be caused by certain medications, some antidepressants, antihistamines, eye drops used for dilation. Anything that causes mydriasis.
Okay. And the pre-existing anatomy, of course.
Right. That underlying narrow angle is the key predisposing factor.
So that leads us nicely into risk factors. Who is more likely to develop AACG?
Okay, several key groups and factors. Older age is one. The lens inside the eye naturally thickens over time, which can push the iris forward a bit.
Makes sense.
Ethnicity is a big one. It's significantly more common in people of Asian descent, particularly Southeast Asian and Chinese populations, and also Inuit populations.
Interesting. Why is that?
It's thought to be related to inherent anatomical differences in eye structure in these groups, like shallower anterior chambers.
Okay. Any others?
Yes. Female gender women are affected more often than men. Family history plays a role too, suggesting a genetic link.
And eye-specific factors.
Hyperopia, or farsightedness. People who are farsighted tend to have slightly smaller eyes overall and often shallower anterior chambers.
Ah, that shallow chamber again. Less room for maneuver.
Exactly. And as we mentioned, medications that dilate the pupil are a risk factor, especially if you already have narrow angles.
Right, that's quite a list to remember for a revision. Is there a mnemonic or memory aid?
There is. The notes suggest picturing an old Asian female
Oh, yeah?
who has farsight, hyperopia, looking at her family history scrapbook
Got it.
under dim lights, causing pupil dilation in her already shallow anterior chamber.
Old Asian female, far sight, family history, dim lights. That's really helpful. Definitely paints a picture.
Hopefully it sticks.
Okay, let's get a bit deeper into the pathophysiology. What's actually happening when that angle slams shut?
So the angle physically closes or becomes critically narrow. That physically obstructs the trabecular meshwork the eyes drain.
Right, and the immediate effect.
Rapid, significant rise in intraocular pressure. The fluid has nowhere to go.
And the damage comes from that pressure.
Yes, that high pressure compresses the optic nerve head, where all the nerve fibers leave the eye to go to the brain. It literally squeezes those delicate nerve fibers. Yeah, and it can also reduce blood flow to the nerve if that pressure stays high for too long.
Permanent damage.
Vision loss.
Yeah, exactly. Irreversible vision loss. That's why it's such an emergency. Every minute counts in getting that pressure down.
Understood. Now, because the symptoms, pain, red eye, blurred vision can overlap with other conditions, we need to think about differentials. What else could it be?
Good point. The notes break this down nicely. Firstly, other things that cause acutely raised IOP.
Okay, like what?
Traumatic glaucoma after an injury. Pigmentary glaucoma, where pigment shed from the iris clogs the drain. And something called glaucomatocyclitic crisis, or Posner-Schlossman syndrome episodes of high IOP with inflammation.
Right. What about things causing acute eye pain and vision loss, maybe without such a dramatic IOP spike initially? You need to consider corneal problems, a bad abrasion, keratitis, which is inflammation or infection of the cornea, anterior uveitis inflammation inside the front part of the eye, scleritis inflammation of the white part, the sclera.
Okay.
Also, endophthalmitis, a really serious infection inside the eyeball, and optic neuritis inflammation of the optic nerve itself, often causing pain with eye movement.
And just the red eye. Loads of things cause that, right?
Oh yeah, simple conjunctivitis, viral or bacterial pink eye, other types of keratitis, eye trauma, lots of possibilities for just redness.
And any systemic things to briefly consider just to rule out, although the eye symptoms sound pretty specific for AACG.
True, the eye symptoms are key, but severe headache and nausea could theoretically be from a nasty virus, or rarely something like a connective tissue disorder flare-up or another infection, but they wouldn't have the acute severe eye pain and vision changes seen in AACG.
Got it. It's about the whole constellation of symptoms. Did we have a memory aid for these differentials too? I think we did.
We did. Try this. For IOP causes, think trauma pigment poses IOP problems. That's traumatic pigmentary Posner-Schlossman.
Trauma pigment poses.
For painful vision loss, think Cusin SEO cause painful vision loss. Corneal, uveitis, scleritis, neuritis optic, endophthalmitis.
CUSNSEO. Got it.
And for the red eye, Concord gives a red eye. Conjunctival corneal trauma.
Concordis. Brilliant. These are super helpful for revision. Okay, let's talk epidemiology. How common is this?
The exact UK prevalence isn't super clear, but it's definitely less common overall than the chronic open-angle type of glaucoma.
But much more common in certain groups.
Yes, as we've had with risk factors significantly higher prevalence in Southeast Asian, Chinese, and Inuit populations.
And the gender split.
Females are affected more often than males. Roughly a 4-to-1 ratio is often quoted.
Wow, quite a difference.
Yeah, and prevalence increases with age, fitting with the lens changes we mentioned.
Any predictions for the future?
The notes mentioned a potential projection of maybe a 19% increase in UK cases over the next decade or so.
So still very relevant. Okay, clinical features. Let's paint that picture again. What is the patient experience and what do we see?
So the patient comes in, often in agony.
Yeah.
Sudden, severe eye pain, often described as deep, boring pain.
Okay.
Rapidly blurring vision in that eye. Seeing those colored halos around lights is quite characteristic.
And physically?
The eye is red, often a specific type of redness called ciliary flush, which is more prominent around the edge of the cornea. They might have a pounding headache, feel nauseous, maybe even vomiting.
And on examination, what are the key signs to look for?
Visual acuity will be down. Check the pupils. The affected eye often has a mid-dilated pupil, maybe oval shape that doesn't react well or at all to light.
Yeah.
Fixed pupil.
Fixed pupil, okay.
Look at the cornea. Might appear hazy or steamy due to corneal edema, swelling caused by the high pressure. Some people might even feel generally unwell, complain of abdominal pain, believe it or not.
Really? Abdominal pain?
Yeah, it's thought to be a vagal response to the severe eye pain and pressure.
Wow. So the note's stress diagnosis is mainly clinical, based on that classic triad.
Absolutely. Painful red eye, reduced vision, fixed mid-dilated pupil. If you see that, alarm bells should be ringing loud for AACG. Urgent referral is non-negotiable.
And history taking is key, too. What specifics are important to ask about?
Definitely ask about the onset, how sudden was the pain and vision loss. Ask about the halos, ask about nausea, vomiting, and crucially ask about potential triggers. Were they in a dark room? Started any new meds recently under unusual stress?
Right. And a specialist eye exam would show.
Elevated IOP on tonometry, usually well above 21 mmHg, often much higher like 40, 50, even 60 mmHg. A shallow anterior chamber. Gonioscopy confirms the close angle. Slit lamp exam shows the corneal edema, maybe some inflammatory cells, and they'll look for any secondary causes.
An important reminder, often only one eye has the acute attack initially, but the other eye likely has the same predisposition, right?
Crucial point. The fellow eye is at high risk and needs assessment and often preventative treatment.
Okay. So, suspicion is high based on clinical features. What investigations nail the diagnosis?
Well, the clinical picture is often very suggestive, but investigations confirm it and assess severity. Fundoscopy to look at the optic nerve, is it already showing signs of damage? Slit lamp exam for that detailed view of the front of the eye.
And measuring the pressure.
Tonometry is essential, confirms the high IOP.
And the gold standard for the angle itself.
Gonioscopy. That's where the ophthalmologist uses a special lens to directly look at the drainage angle and see that it's closed.
Any role for other imaging, like OCT?
Sometimes.
Yeah.
Anterior segment OCT can provide detailed images of the angle structures, which can be helpful, especially if the cornea is too hazy for good gonioscopy initially or in chronic cases.
Are there formal diagnostic criteria listed for, standardization?
Yes, the notes mention criteria needing at least 2 symptoms, like the eye pain, nausea, vomiting, or history of intermittent blur, halos, A&D, at least 3 signs.
Signs
Like IOP over 21, the conjunctival injection, redness, corneal edema, that mid-dilated non-reactive pupil, and the shallow chamber with occlusions seen on gonioscopy.
Okay, so a combination of symptoms and signs confirms it, right? Management, this is critical. What's the immediate priority?
Get the pressure down, fast,
Yeah.
and relieve the pain and nausea. It's an emergency, so immediate action.
What are the tools for doing that?
It's usually a combination approach. Medications first to break the acute attack, then usually a definitive procedure like laser or surgery later on.
So step 1, urgent referral to ophthalmology.
Absolutely. But while waiting, or in the emergency department, you start medical treatment immediately.
What does that typically involve? The notes mentioned a sort of cocktail.
Yeah, there isn't one single rigid protocol, but a common approach is multiple eye drops. Maybe pilocarpine to constrict the pupil and try to pull the iris away from the angle, although its effect can be limited when the pressure is very high. Definitely drugs to reduce aqueous production like topical beta blockers, timolol, and alpha agonists, epreclonidine or bromonidine. And often systemic medication too, usually intravenous or oral acetazolamide, a carbonic anhydrase inhibitor, which really cuts down fluid production.
So attacking it from multiple angles, trying to open the drain and turning down the tap.
Exactly. Sometimes, if pressure is still stubbornly high, hyperosmotic agents like intravenous mannitol might be used in hospital to draw fluid out of the eye.
And then once the pressure's starting to come down, what's the definitive fix?
For primary angle closure, the mainstay is laser peripheral iridotomy LPI.
Explain LPI again.
The laser creates a tiny hole in the outer part of the iris. This acts like a release valve, allowing the aqueous fluid trapped behind the iris to flow directly into the anterior chamber, bypassing the pupillary block. This lets the iris fall back, opening up the drainage angle.
Clever. Is that usually done straight away?
Often done once the acute inflammation and corneal edema have settled a bit with the medical treatment, maybe within 24-48 hours. And very importantly, it's usually done on the other eye too, prophylactically.
Ah, preventing an attack in the fellow eye. Smart. Are there other surgical options if LPI isn't enough?
Yes. Sometimes laser iridoplasty is used to shrink the peripheral iris, or surgical options like removing a piece of the iris, rhodectomy, creating a whole new drainage channel, trabeculectomy, or inserting tiny drainage tubes, aqueous shunts. These are usually reserved for more complex or refractory cases.
And don't forget managing the patient's distress.
Absolutely crucial. Good pain relief analgesia and anti-sickness medication antiemetics for the nausea and vomiting makes a huge difference to the patient's experience.
And always remember, for secondary AACG, you have to treat the underlying cause too.
Yes, finding and managing whatever is pushing the iris forward is key in those cases.
So the mantra is break the attack medically, then definitive treatment, usually LPI, and always consider the fellow eye and any underlying causes.
You've got it.
Okay, what about the long-term outlook? The prognosis.
If it's caught and treated quickly, the prognosis can actually be very good. Vision can often be saved, symptoms resolve completely.
But the key word is quickly.
Absolutely. Delay means more risk of permanent optic nerve damage and irreversible vision loss. That's the nightmare scenario we're trying to avoid.
So follow-up is important.
Essential. Regular checks with the ophthalmologist to monitor the pressure, the optic nerve, and the angle status.
Can it happen again?
The LPI significantly reduces the risk of another acute attack in that eye. That's why it's so important. But ongoing monitoring is still needed.
And the risk for family members.
Yes, first-degree relatives, especially if they also have shallow chambers, are at increased risk. They should be encouraged to have regular eye exams.
The notes also briefly touched on chronic angle closure glaucoma again here. Just remind us.
Right. COAG is different. It's a slow, gradual scarring and closure of the angle over time, often asymptomatic until significant damage is done, more likely bilateral, more common in women, and hypermetropes.
And treatment.
Often involves LPI in both eyes promptly, but frequently needs ongoing pressure-lowering eye drops as well, similar to open-angle glaucoma management. The prognosis depends on early detection and control.
Okay, good distinction. Finally, what are the potential complications if things go wrong with AACG or treatment is delayed?
The big one, the most feared, is irreversible optic nerve damage leading to permanent vision loss. That's complication number one.
Right. Anything else?
Well, if the underlying angle issue isn't fixed, you could develop chronic angle closure glaucoma down the line. There's also the risk of a repeat acute attack or an attack in the fellow eye if it wasn't treated prophylactically.
Any other rare things?
Very rarely, the super high pressure could lead to a blockage of the main blood vessels in the retina, a central retinal artery or vein occlusion, but that's less common.
Okay, so let's wrap this up. Key takeaways for acute angle closure glaucoma.
It's a serious sight-threatening emergency. Needs fast recognition, immediate medical treatment to lower pressure, followed by definitive treatment, usually LPI.
Understanding the risk factors, remember our old Asian female mnemonic and the classic symptoms, sudden severe pain, blurred vision, halos, fixed pupil is crucial.
Absolutely. And effective treatments are available if you act quickly.
The bottom line, sudden severe eye pain, blur, halos, get immediate medical help. Go straight to A&E or an eye casualty department.
Don't wait. And for anyone revising for exams like the MSRA, this is high-yield stuff. Definitely check out resources like passthemsra.com and freeansra.com for more practice.
Great suggestions. And a final thought to leave everyone with.
Yeah, it's quite something, isn't it? How such tiny anatomical variations in the eye's drainage system can lead to such a dramatic and potentially devastating condition really highlights the intricate design and delicate balance within our bodies.